Welcome. My name is Stephen Kahn. I'm from the VA Puget Sound Healthcare System in the University of Washington, Seattle. And I have the good fortune also to be editing Diabetes Care. And it's my pleasure to welcome you to the very first Joint Diabetes Care Centers for Disease Control and Prevention Symposium. This symposium is part of a new initiative that Diabetes Care has put together with the CDC that will hopefully go for at least the next 3 to 4 years and beyond, where we're trying to publish in Diabetes Care twice a year novel data related to diabetes that you otherwise are not getting off the website. That is then presented in a paper that is used as part of the foundation for a full symposium. So today we have a paper that comes from CDC, and then, as you will hear, 2 other talks that relate to the field of future directions in the prevention of acute and chronic complications. And in addition, we have a commentator who will then review those 3 presentations which she has seen and tell you her thoughts on all of this. And the goal at the end of the day will be to publish all 3 papers and the commentary in a future issue of Diabetes Care. And we're getting really close because all 3 papers have been submitted. And I will tell you about something else that's also really interesting and exciting towards the end. I should also add that the first paper in this whole series came out in December last year, and the next one will have to be submitted soon because it's supposed to come out in December, January of this coming year. And we've identified the different topics that we're going to do with CDC over the time. It's my great pleasure to say also that none of this would have happened without the help of my good friend over here, Christopher Holliday, who many of you who went to the opening ceremony would have seen sitting up there with all the big names in diabetes. As you also heard, Christopher and his group have sponsored $90 million worth of funding towards diabetes care and prevention, which is amazing. And I think without leadership like his, the leadership he brings, none of that would have happened. And it's been wonderful to partner with Christopher and the other people at CDC on this initiative, and particularly Kay Bullock and Stephen Benoit, who've been phenomenal in this process. And so I'm really excited now at this stage to sit down and let Christopher say a few words and introduce the first speaker.
All right, thank you, Stephen. So hello, everyone. Christopher Holliday. I'm the director of the Division of Diabetes Translation at CDC, and I'm just going to bring some brief remarks, and we're going to get out of the way and bring our speakers up. But we're so excited to collaborate with Diabetes Care as well as the ADA on this symposium. This has been a labor of love, as Stephen mentioned, for at least the past year or so, as we started to talk about setting up a relationship between ADA and Diabetes Care where we can start to highlight some of the great work that we do. CDC houses one of the most robust diabetes surveillance systems in the world, and produces the widely cited National Diabetes Statistics Report. Many of you have probably seen it, but this is a report that we send to Congress, both of which have provide a compilation of diabetes data from multiple data sources. And although comprehensive, we're not able to go into too much depth on specific topics. But this collaboration that I just noted really highlights and gives CDC a greater opportunity to go into detail on topics of importance to the readership of Diabetes Care. And so we're grateful for that. We at CDC's Division of Diabetes Translation believe in the power of putting that science into action, as you heard this morning, through programs and policies that help people prevent type 2 diabetes and improve the health of everyone living with diabetes. Through our collaboration with ADA and Diabetes Care, we're honoring this commitment to be accountable to the highest standards of excellence and scientific value ensured by the peer review process. We hope that you'll support us in this exciting new collaboration. The last thing I'll say is today's topic is an important one. In particular, incidence of diabetes-related complications improved dramatically in the 1990s and early 2000s due to multiple factors, including improvements in diabetes care, risk factor management, integration of care, among others. However, as you heard this morning from Dr. Califf, beginning in 2010, we started to see a reversal in this success. We'll hear more in a few minutes about the most recent changes in the diabetes-related complications. It's now important to reassess where we are with diabetes complications, to reevaluate the effectiveness of our current tools for diabetes management and treatment, and to plan for innovative public health interventions to relieve the pressure and turn the tide. So it is my great pleasure to introduce our first speaker, Dr. Ryan Saley. Dr. Saley is an epidemiologist at the Centers for Disease Control and Prevention. During his time with the Division of Diabetes Translation, he conducted research focused on examining trends in diabetes inequalities, as well as the impact of social factors such as food insecurity and racialized economic segregation on diabetes-related outcomes. His research interest is in advancing health equity through addressing the social determinants of health across the life course related to chronic diseases. Let's welcome Dr. Saley.
Thank you for the introduction. Here we go. Cool. Hi, everyone. Today I'll be presenting on the trends and inequalities in diabetes-related complications among U.S. adults from 2000 to 2020. I have no conflicts of interest to disclose. Yeah, why is it going the wrong way? Yeah, so I have no conflicts of interest to disclose. And you can take photos of this presentation. So here's a brief background about the importance of our study. So in a previous study, they found that there was a resurgence in diabetes-related complications from 2010 to 2015 among young and middle-aged U.S. adults. However, data on trends for those complications after 2015 among U.S. adults have been lacking. So it would be important to understand these recent trends in diabetes-related complications, as that could help inform secondary prevention efforts. So the purpose of our study was to examine trends in diabetes-related complications among U.S. adults with diagnosed diabetes from 2000 to 2020, and then assess the trends in age, sex, and racial ethnic inequalities. So the 6 different complications that we assess include heart failure, myocardial infarction, which I'll refer to as MI, stroke, end-stage renal disease, which I'll refer to as ESRD, non-traumatic lower extremity amputations, which I'll refer to as NLEAs, and then hyperglycemic crises. So data for heart failure, MI, stroke, NLEAs, and hyperglycemic crises came from the National Inpatient Sample, also known as NIS. And this is a nationally representative sample of hospital inpatient stays across 48 states. Diabetes-related complications were ascertained based on ICD codes listed as the primary diagnosis among patients with diabetes. And data on ESRD among those with diabetes came from the United States Renal Data System, also known as GSRDS, and this is a clinical and claims-based registry from CMS. And the number of U.S. adults with diagnosed diabetes were estimated using the National Health Interview Survey, also known as NHIS, and this was based on self-report. So the demographic subgroups we included were age, and that was categorized as 18 to 44, 45 to 64, 65 to 74, and then greater than or equal to 75 years of age. Sex included female and male. And for race and ethnicity, that included Hispanic, non-Hispanic Black, and non-Hispanic White. There were other racial and ethnic groups that weren't presented here, but then they were included in the overall age and sex-specific estimates. So we selected 2 measures of absolute inequalities, and one of those was the between group variance, also known as the BGV, and this is typically used for nominal variables such as race and ethnicity and sex. And so the BGV represents the variance that would exist if everyone had the mean probability of having that specific complication of their social group. And to interpret the value, a BGV of 0 indicates no inequality, while a larger value away from 0 represents greater inequality. The other measure of inequality we used was the slope index of inequality, which I'll refer to as the SII, and this is typically used for ordinal variables, and in our case, age. And so typically this represents the average health status between the most and least advantaged groups while accounting for all the other subgroups. So in our study, a negative SII for age represents a higher concentration of complications in younger age groups, while a positive value represents a greater concentration of complications in the older age groups. And for this, a value of 0 also represents no inequality. And for the analyses, the annual rates of complications from 2000 to 2020 were estimated by taking the weighted number of hospitalizations, or in the case of ESRD, the incident cases, and we divided that by the weighted number of adults with diagnosed diabetes that we calculated from NHIS. And this was age standardized to the US 2000 census standard population. And for the race and ethnicity specific calculations, we were only able to calculate those for 2012 to 2020 due to incomplete data in NIS. And after we calculated the annual rates, the BGV, and the SII for each complication, joint point analyses was conducted to identify trend segments between 2000 to 2020. So joint point analyses allowed us to estimate the annual percent change, also known as APC, for each of the trend segments. And then we were also able to calculate the average annual percent change, also known as the AAPC, for the overall trends for the rates, BGV, and SII. And statistical significance for the trends were assessed with a two-sided p-value of less than 0.05. So now I finally can go into the results. So here are the overall trends for each of the diabetes complications. So to interpret these figures, the solid lines here represent a significant trend, while the dashed lines represent a non-significant trend. And the arrows represent a shift in the trend. And the dots here represent the actual observed values. So here we see that for heart failure, stroke, NLEA, and ESRD, there was a decline in the early 2000s, but then they started to increase again around the 2010s. And for hyperglycemic crises, there was a steady increase from 2000 to 2020. And for MI, we see that after the decline from 2000 to 2009, the rates remained flat after. And next, I'll be presenting the age, sex, and race and ethnicity specific trends and inequalities for each of the complications, starting with heart failure. So for the age trends, we see that based on the figure on the left, we see that around 2012, the rates started to increase for all the age groups younger than 75. But for those 75 and older, the rates did not significantly change after 2012. And from the figure on the right, examining the trends in age inequalities, we see that there was a decline in age inequalities as the SI again moves closer to zero from 2000 to 2012. But then it increases again from 2012 to 2018, and then declines again from 2018 to 2020. But based on the AAPC, again, which is the average annual percent change, there was an overall decline in age inequalities. And for the race and ethnicity specific trends, we see that hospitalizations for heart failure increased in all the racial and ethnic groups, with non-Hispanic blacks having roughly double the rates of non-Hispanic white and Hispanic adults. And we see that the racial and ethnic inequalities actually increase over time based on the trends in the BGV, which is moving away from zero, as you can see. And for the sex-specific trends, we see that hospitalizations among males surpassed those of females beginning in 2005, and then both sexes had steady increases in heart failure during 2012 to 2020. And for the inequality trends, we see that there was no significant changes from 2000 to 2020 based on the dashed lines. Next, I'll present results for MI. And for the age-specific trends, we see that there was a decline in the early 2000s for those older than 44 years of age, with an increasing trend only for those 45 to 64 years of age after 2009. And you see that there was no significant trend from 2000 to 2020 for those 18 to 44 years of age. And then for the trends and inequalities, we see a decline from 2000 to 2010, but then no significant changes thereafter. And based on the AAPC, you see that there's actually an overall decline in age inequalities from 2000 to 2020. And here you see that there were no significant changes for any of the racial and ethnic groups, and then there was no significant changes in inequalities from 2000 to 2020. And for the sex-specific trends, you see that males had higher MI hospitalization rates than females. There was a decline for both female and males in the early 2000s, but for females, there was no significant change after 2006, while there was a slight increasing trend for males after 2009. However, there was no significant changes in the sex inequalities from 2000 to 2020. And next, I'll be presenting the results for stroke. For stroke, for the age trends, you see that adults 75 and older had the highest rates throughout, with the decline from 2000 to 2006, but then remained flat after. And those younger than 65 years of age were the only ones experiencing an increasing trend. And you see that there was a decline in age inequalities from 2000 to 2014, and then a non-significant change from 2014 to 2017, and then you see that there's a significant decline in 2020. And so based on the AAPC, there was an overall decline in age inequalities from 2000 to 2020. Next, for the race and ethnicity specific trends, you see that non-Hispanic Black adults had the highest rates throughout, and that there was an increasing trend from 2012 to 2020 across all the racial and ethnic groups, as well as increasing racial and ethnic inequalities. And for the sex-specific trends, you see that males and females had actual similar stroke hospitalization rates based on the observed values. And you see that there's been an increasing trend in the last decade, and you see that there was an overall increase in sex inequalities from 2000 to 2020. And next, I'll be presenting the results for ESRD. And so here, for the age-specific trends, you see that there was a decline in the early 2000s into the 2010s for those older than 44 years of age. And this remained flat after 2011 for those 65 to 74 years of age, while those 75 and older experienced a decline after 2016. And only those between the ages of 45 to 64 experienced a steady increase in ESRD after 2010. And you see that there was no significant changes for those 18 to 44 years of age. And based on this, you see that there was an overall decline in age inequalities from 2000 to 2020. Next are the race and ethnicity specific trends. Here you see that non-Hispanic Black adults consistently had the highest rate of ESRD. However, only non-Hispanic whites had an increasing trend, while there was no significant change for the other two groups, resulting in a declining racial and ethnic inequalities from 2012 to 2020. And for the sex-specific trends, males had higher ESRD rates than females. Both groups had declines in the early 2000s, where there was no significant changes for females after 2009, but then you see there's an increase for males after 2010. And because of this, you see that sex inequalities actually increase overall from 2000 to 2020. And next, I'll present the results for NLEA. Here for the age trends, you see that except for those 75 and older, NLEA hospitalizations increased in the past decade for all the age groups, with the 45 to 64 year age group increasing at the highest rate. And for NLEAs, we were actually unable to estimate the trends in age inequalities due to having both positive and negative SII values causing issues in our joint point models. And for the race and ethnicity specific trends, you see that non-Hispanic Black adults had the highest rates of NLEA hospitalizations during 2009 to 2019, but then had the same rate as non-Hispanic white adults in 2020. And you can't see it here, but the dots, the observed values actually overlap in 2020. And you see that there was an increasing trend for all the racial and ethnic groups from 2012 to 2020, while there were no significant changes in the inequalities during that time period. And for the sex-specific trends, you see that males had higher rates of NLEA hospitalizations throughout, with both sexes having increasing rates of NLEA hospitalizations after 2009. And males had a higher rate of increase, leading to a significant increase in sex inequalities during 2009 to 2020. And finally, I'll be presenting the results for hyperglycemic crises. So here you see that those aged 18 to 44 years of age had the largest number of hospitalizations with at least 5 times higher rate than the other age groups. All other age groups had an increasing trend in the last decade, but the 18 to 44 year age group, you see that there's been an increase steadily since 2000. And you see that age inequalities overall increase throughout as the SI actually becomes more negative, moving away from 0. And for the race and ethnicity specific trends, you see that non-Hispanic Black adults had the highest rate of hyperglycemic crises and was the only group with a significantly increasing trend during 2012 to 2020, resulting in a significant increase in inequalities during that time period. Here, based on the observed values, you see that males and females had similar rates, but the gap widened in the last decade, with males having a slightly higher increasing rate during 2009 to 2020, and there were no significant changes in sex inequalities. So I know I presented a lot of results, and I went over quickly. So next, I'll just provide a summary of the results, and this is taken from the visual abstract of the paper. So we saw that despite declines in the early 2000s, during the last decade, rates of diabetes-related heart failure, stroke, NLEAs, and ESRD have increased. And we also saw that hyperglycemic crises increase in the past 20 years, and MI remained constant after 2008. And we observed that age, sex, and racial ethnic inequalities have worsened for some complications, with the most alarming findings of increasing trends for age groups 18 to 44, 45 to 64 years of age, for males and non-Hispanic Black adults. So there are several factors that may explain the increasing complications among younger adults less than age 65. One of those factors could be the rising cost of diabetes care, such as insulin and other diabetes medications. And this particularly affects younger age groups less than 65 years of age because they're more likely to be under or uninsured. In addition, we saw that there's been an increase in enrollment in high deductible health plans among those less than 65 years of age. And this may have contributed to a reduction in diabetes monitoring, routine care, and medication adherence, and also an increase in acute healthcare utilization. In addition, our previous study has found that achieving glycemic and lipid targets had declined in recent years. And obesity, a risk factor for many of these complications, is high for all age groups, but severe obesity is higher among those less than 60 years of age, and the rates have been increasing over time, a trend not seen in those greater than 60 years of age. And finally, increases in substance use disorders in general among younger populations may play a role in the rise in complications, given that substance use disorder is associated with poor glucose control and an increased risk of diabetes-related complications. So differences in access to healthcare and quality of care may explain the growing racial and ethnic inequalities, especially the persistently high rates of heart failure, stroke, ESRD, and hyperglycemic crises observed among non-Hispanic Black adults. For example, research suggests that Hispanic and non-Hispanic Black adults are more likely to be under or uninsured, and those enrolled in high deductible health plans are less likely to have health savings accounts, making them more vulnerable to suboptimal care. In addition, a previous study had found that non-Hispanic Black adults are less likely to receive HbA1c and lipid testing. And the disparity specifically observed for NLEAs with the higher rates among males may be attributed to higher rates of peripheral neuropathy, peripheral arterial disease, and cardiovascular disease, as well as poorer self-care practices among males. So there are some limitations to this study. One is that NIS data is event level and not patient level data, so there is potential that many of the hospitalizations could have been readmissions and not unique patients. Thus, that may have led to some overestimate of hospitalization rates. Also, we were only able to assess inequalities across Hispanic, non-Hispanic, Black, and non-Hispanic white adults due to the limited sample size of the other racial groups, so they weren't represented here. Also, we weren't able to examine trends by diabetes type due to the potential misclassification of diabetes type in the NIS data set. And finally, we use hospitalizations as a proxy for complications, and they may not be equivalent. But despite these limitations, there are some strengths to the study. One is that NIS is a nationally represented data set that represents the majority of US hospitals, and we had data spanning 2 decades. Also, the summary measures we use to monitor inequalities over time accounts for changes in population size over time, and it also allows for the ease of summarizing the results and communicating the results, because again, we use a single value. So in conclusion, our results highlight some important populations of focus to prioritize and tailor diabetes secondary prevention efforts on. In addition, this study underscores the importance of trying to reduce inequalities and reversing these growing trends, as well as continued surveillance to monitor progress. And that's it. Thanks.
Thank you, Dr. Saley. And we're going to hold questions into the end. We're going to have the discussant come, and then we're going to open it for questions to the audience. So if you can hold your questions, please. Next, we're going to have Dr. Francisco Pasquel. Dr. Pasquel is an associate professor of medicine and global health at Emory University in Atlanta. He serves as co-director of the Regional Technology Core of the Georgia Center for Diabetes Translation Research. His research is supported by NIDDK, and he currently serves as associate editor for JAMA Network Open. He provides care for patients with diabetes at Grady Health System, also in Atlanta. Let's welcome Dr. Pasquel.
Thank you. Thanks very much for the invitation. Let's open the slides. Okay.
It takes a minute.
Okay. So we wanted to focus for this symposium on microvascular complications, and there's a lot of data on diabetic retinopathy prevalence. There's a great increase in the interest of using telehealth, teleretinal imaging to improve care for our patients. So we wanted to understand a little bit of what are the next steps of care when we identify these patients at high risk, because there's a lot of descriptions of how prevalent it is and how there are disparities. For example, this is national data from the CDC in 2021. Shows that about 1 in 4 patients with diabetes have diabetic retinopathy. And on the left side of the figure, you can see that there's disparities. This is distributions by age. You can see that Hispanic, Latinos, and non-Hispanic Blacks have the highest rates. And this is the distribution in the country. Oh, this was supposed to go. before. Sorry about that. So this data just came out a few weeks ago, showing that the prevalence of diabetic retinopathy hasn't changed that much over time, but here the analysis by gender and ethnicities shows that Hispanics have the highest risk for retinopathy and the highest prevalence in this case in this study. So this is something of interest that came out after we completed our analysis. And I just wanted to show you a little bit of what we have from data from Latin America, from where I'm from Ecuador. So you can see this line here in the middle. This is stratified by gender. And for those people that have had an eye exam or a foot exam in the last 2 years. And this paper was published recently by Carrillo Larco from Emory. And you can see how often we're screening our patients for diabetic retinopathy or for foot exams. So it's extremely low. And maybe there's some disparities in gender. Maybe male tend to go less to the doctor, me included. So what we wanted to look is into how are we doing in terms of meeting guidelines of care. So what does ADA recommend? So we should at least check for our ABCs, A1C, blood pressure, cholesterol, and we should at least have an annual primary care visit and at least one annual ophthalmological screening. So if you have diabetic retinopathy, you should be following up with your doctor to make sure it's not progressing. So we analyzed the EPIC Cosmos dataset, and here a big shout out to Jithin, who did a lot of work with this dataset to analyze it. Is analyzing millions of patients. The system is still crashing. We're still getting there, but he's been leading the efforts at Emory for EPIC Cosmos, and I think the work that is being done with this database is showing us a lot of new things that are maybe a little bit easier to look at the national level, because this database is representative for the U.S. So we looked at the role of urban residents, race and ethnicity, and glycemic control in receiving the standards of care and progression to vision-threatening diabetic retinopathy. So we wanted to do a real-world analysis with largest EHR records of adult patients that had a new diagnosis of non-proliferative diabetic retinopathy without macular edema. So early stages of diabetic retinopathy, and we analyzed the data from January 2015 until December of last year. And we looked at geographic distributions, rural and urban. And the data set includes over 250 million people, more than 1,500 hospitals, and here on the right is just to show you how this data set may be representative of the U.S. census. We included patients older than 18 with type 1 or type 2 diabetes that had at least one encounter before our index date, so 2 years before. And then we had a new diagnosis of retinopathy. So new diagnosis of retinopathy in patients with type 1 or type 2 diabetes. We stratified the analysis by urbanicity. And we also looked into glycemic control. We categorized glycemic control by A1C levels less than 7, 7 to 9, and more than 9. And we also analyzed data from patients that didn't have an A1C checked. So this is patients that were supposed to have an A1C but didn't have one, so A1C unavailable. And meeting standards of care included at least 2 of the following criteria: at least having 1 visit per year to an ophthalmologist, to a primary care doctor, and at least 1 screening each year of ABCs, A1C, blood pressure, lipids. Here are the definitions again: NPDR at baseline, and then any progression will be NPDR with macular edema or proliferative diabetic retinopathy, and those will be the vision-threatening retinopathy levels. So this is the whole data set and how we got into our sample. Started with over 240 million people, and ended up with 100,000 people with new diagnosis of non-proliferative diabetic retinopathy. And here's the distribution of the analytical sample across 50 states from the US. This data shows the age distribution, rural versus urban, about 60 years, mostly white in rural areas compared to urban, but otherwise similar distributions of types of insurance, proportion of people with type 1 diabetes with NPDR, 30% rural and 28% urban. And these are the proportion of people that on follow-up had NPDR. So actually 50%, if you follow them enough, 50% of these patients that had NPDR had a progression in disease. NPDR with DME being the most common, so macular edema. Severe, about 10% of people, and this occurred about 35 months from the index date. When we looked at the proportion of people with rural and urban residents, we analyzed this by meeting the standards of care. You can see ophthalmology, primary care, A1C, blood pressure, LDL. There's not enough ophthalmologists, as you can imagine, so very, very little follow-up with ophthalmology after having a diagnosis of retinopathy. But the distributions in terms of going to the doctor, getting an A1C checked, blood pressure and LDL cholesterol, relatively similar according to urbanicity. Obviously not ideal in either side. In terms of progression to vision-threatening diabetic retinopathy by glycemic control, no major difference between rural and urban, but as you can see here, what you will expect is that those patients that had higher A1Cs at baseline had the highest rate of progression to vision-threatening retinopathy. And if you didn't have an A1C checked, then your rate to progression was much, much higher compared to those with lower A1C levels. And when we looked at the association of meeting the standards of care in those 2 years after the diagnosis, and we can see that the proportion of this will be a risk ratio. The chances of getting this standards of care were much lower among those that have the highest A1Cs. So if you have a high A1C to start with, it's much less likely that you will have follow-up, that you will have additional care. So these are, to start, high-risk populations, and unfortunately, we're not providing the care that they deserve. And in terms of progression to vision-threatening retinopathy, those with higher A1Cs, more than 9, have a 60% increase in the hazard of progressing to diabetic retinopathy. Obviously, the higher the A1C, the higher the risk. Also for those between 7 and 9%, a 21% increase. If you didn't have an A1C available, it's unlikely that you will meet the standards of care. About only half of them with diabetic retinopathy had follow-up, met the standards of care in the next 2 years. And when we looked at race and ethnicity, particularly Hispanics had a lower likelihood of meeting the standards of care, but really non-Hispanic blacks and Hispanics still had an increase in risk of progressing to diabetic retinopathy compared to non-Hispanic whites. This is the data showing compared to a reference of an A1C less than 7 by race and ethnicity. Again, those with highest A1Cs, or if you didn't have an A1C checked, had the highest progression to vision-threatening retinopathy. So what can we do? I think the data shows us what we expect. There was not increased risk in rural areas. There's actually a slight 7% increase in urban areas. So what can we do? This is a nice example from the work of Ashby Walker when they looked at neighborhood deprivation index and looked at geocoding, looking at providers in that area when they're conducting this ECHO program to provide care in rural areas. And when they try to identify the spokes that will reach out to people that have less access, they try to see where the areas of highest deprivations were. And then, as you can see here, on the left side is showing neighborhood deprivation index. The darker the color, the more the deprivation. And on the right side is showing you the data on how far a PCP or an endocrinologist is. And obviously, you can see that this overlap of the highest deprivation with less doctors. So kind of telling you where there's more need, and there's the areas that you can potentially identify where you can intervene. In this case, if we're interested in diabetic retinopathy, probably those are the areas that we may want to start thinking about teleophthalmology. This is just putting here the two papers together showing that probably, I think if you may agree with me that here the highest areas of deprivation is where the most retinopathy is happening. So what do we do at Grady? This is where I work. I take care of patients at an inner city hospital, most of them with less resources, socioeconomic deprivation. And in our hospital, over time, we've had leadership that has been thinking about addressing fragmentations of care, trying to put interdisciplinary teams to take care of our patients. And really a shout out to Dr. David Seamer, who has been working with ophthalmology primary care clinics to implement telehealth. And on the other side, more recently, in recent years, the work of Doctors Feifman and Schechter with a diabetic foot program to integrating the different specialties. This is at an inner city hospital, is not addressing rurality, but at least this is a potential way to try to address the problem. This is an example of what the work that they're doing in the inpatient and outpatient setting, the roles of the different teams, vascular infection, metabolic control. So there's pathways already approved in the hospital. I think they're getting funded for a new approach in integrating a navigator. So it's really nice work that they're doing. And then in the area of retinopathy and screening, the BPAs, for example, best practice advisories, we get a message or an alert that the patient needs a diabetic retinopathy. There's a pathway. We put the order in. Where every patient that doesn't have a retinal exam in the last year will get them just because of this. Then we have these cameras in primary care clinics, and those images are read remotely. And then there's critical results that go to the ophthalmology clinic, and then the patients get a call to come and see the doctor. Obviously, the question here is how many of those patients that get the message, get the schedule and visit, actually come to the visit and actually get the treatment and actually get the therapy that will prevent them to progressing. So there's still work to do. And I just wanted to conclude that showing you that there's still significant disparities in diabetic retinopathy, as you already know, but those disparities persist. So we diagnose our patients with diabetic retinopathy. Unfortunately, they're not really getting the care that they need, and there's still a lot of work to do in this area. So I think there's potential for telehealth. We are seeing that it works, but there's a lot of work to do in this area still. And I will end with that. Thank you.
You can do Josh. You can do Josh.
Thank you very much, Francisco. So our next speaker is Joshua Joseph. Joshua is an associate professor of internal medicine and an endowed professor for research in internal medicine at, and I say this, the Ohio State University. And he is a member of the No Diabetes by Heart Scientific Advisory Group. His work is focused on advancing the prevention and treatment of cardiometabolic disease, and he does so through a health equity lens using 4 pillars: epidemiology, health system, community partnerships, community-based participatory research, and quality improvement science. And he's going to talk to us today about some of the work he's been doing in this area with some new data. I hope we could. There we go, Josh. Did it come up? There we go.
Well, perfect. Thank you. Well, thank you so much to the American Diabetes Association, to Diabetes Care, to the CDC, and to all of you for being here today. I think this is a critically important session as we move forward diabetes treatment and care. Here are my relevant disclosures. So our objectives today are to talk about some approaches to diabetes treatment that reduce cardiovascular risk, discuss the current state of cardiometabolic risk in diabetes, and then give some real-world examples of interventions to advance cardiometabolic health as well as health equity. And so we'll start here with why cardiometabolic disease. So who in the audience, by chance, has a grandmother? Anybody with a grandmother? Okay, a few people. Some of you don't have grandmothers. I don't know how it all came to be. That's a whole nother story. I think that's a whole nother topic for another session that the CDC and Diabetes Care should put on. But this happens to be my grandmother. This was a woman from the South. She grew up in Louisiana. She was a school teacher, master's trained. And she came to live with us when I was young. So the little guy on the left there, that may or may not be me. And I had a car, which was good. So I was rolling around. I had some wheels. The outfit, I don't know about, right? Nothing to do with that. But the pivotal thing about my grandmother, she had diabetes. And I would see her give herself insulin injections every day. And I also remember the first day that she left our house clutching her chest. In this room, we know that she was having a heart attack. Went to the hospital. They opened up one of her arteries, came back home. But a few months later, she went to the hospital and never came home. So today, we're talking a lot about data points, right? We're talking a lot about trends and prevalence and different pieces. But there's people behind these numbers, right? And it's the people, and that's what really brings us here today, right? Because if complications from diabetes didn't have an impact on us, we wouldn't have this session, right? It's all about the people and how that impacts other folks, other family members, other community members going forward. And so let's talk about a tale of type 2 diabetes. Any Dickens fans in the audience? Anybody like Dickens, right? So we're going with A Tale of Two Cities here, right? It was the best of times. It was the worst of times. Everybody, okay, good. So on the left of this slide, we have the best of times, right? We have trees. We have wonderful houses. There's actually pools in there. It's where you want to live. And on the right side, there are some challenges. You can see those challenges. There's absolutely no trees, right? The infrastructure is far less than what we see on the left side of the slide. And so, Dr. Califf earlier kind of set this up, right? That we're doing really well on some things, but not as well on others. And in 2022, we wrote a guideline on comprehensive management of cardiovascular risk factors for adults with type 2 diabetes. And in this, we talked about 7 different areas that we thought were really, really important, 6 of them that are noted on this slide. And so I'm going to take you through one of them to talk about really the best of times in many ways. And so that's lipid management. So in lipid management, we have a number of medications, right, that are effective in reducing cardiovascular risk. We start with our old standard, statins, right, and they reduce risk of MACE, they reduce risk of stroke, as well as major vascular events. And these are large reductions in risk for individuals. When we moved forward, we had statin plus ezetimibe. And we looked at that, and that was actually even more impactful among folks with diabetes compared to folks without diabetes in that trial. And so, large reductions in cardiovascular disease here with statins plus ezetimibe. We go forward to PCSK9 inhibitors. We use the example here of alirocumab in the Odyssey trial. Once again, 16% lower risk of major adverse cardiovascular events, right? These are the best of times. And we have great agents that are lowering cardiovascular risk. And more recently, we have bempedoic acid, right? Clear outcome study where we had in diabetes a 17% lower risk of major adverse cardiovascular events. And almost half the participants in Clear had diabetes. One important other finding from that study was there was no increase in A1C, and the rates of new diabetes were not elevated in that study as well. And then we also have siRNAs that target the PCSK9 pathway. And in that study, about a 20% lower risk of major adverse cardiovascular events in a pooled analysis of Orion 9, 10, or Orion 9, 10, and 11. And notably, it's FDA approved as an adjunct to statin to lower LDL in those with ASCVD, FH, or high cardiovascular risk, including diabetes, like we're talking about today. So these are truly the best of times. I could go through that with blood pressure meds. I could go through that with diabetes medications and diabetes technology. You know, it is truly the left side of this slide in diabetes treatment and care. We've gone through an oasis over the last 15 to 20 years with new medications that we never had before. So let's talk about the right side of the slide, and let's look at the prevalence of diabetes control. We know that 1 out of 2 individuals meets a target of less than 7%. And you saw in the last presentation how critically important that is to reduce microvascular outcomes, using the example of retinopathy. We also know when you look at the ABCs of diabetes, A1C, blood pressure, and cholesterol, only 1 in 5 individuals is hitting targets here in the United States for those with significant disparities in minoritized, rural, and lower socioeconomic status populations, consistent with much of the data that you've seen so far in the presentation. We also know when we look at multifactorial risk factor control most recently, and this is in the 2024 report, that 11% of individuals meet the category when we include smoking, cholesterol, blood pressure, and A1C. If we use less stringent targets, we get up to about 37%. Important for this conversation, the ADA is a national organization. I love the CDC, but you know, we think about the world too in the ADA. When we do that, I gave you some data from Switzerland. The rates of control aren't necessarily much better. 17% when we use fasting glucose, 27% when we use A1C. So this is a challenge really around the world. And when we look at this challenge around the world, why is this a big issue? Well, it's a big issue when we think about the macrovascular disease, because the more risk factors that are controlled, the lower your rates of cardiovascular disease, right? That's not a surprise to anyone in this room, right? And there's a trend for even lower CVD event rates among the most marginalized communities, including Black communities versus non-Black communities. And this is some data from Nathan Wong back in 2016, published in Diabetes Care. We also know that there's been a flattening of the reductions of CVD mortality, and this is overall. And you got to see the data today, right? Right here in person on cardiovascular disease in diabetes. And we also know diabetes mortality in general has been climbing. So with that, let's talk a bit about what are some potential solutions. I hope I've covered like why we need these solutions in diabetes. Well, one of the things that I've been working on with many others around the country, maybe some in this room, is really trying to think about new guidelines and new disease processes. This is around cardiovascular, kidney, metabolic health. Starting with on the left, individuals with no risk factors, stage 1 with excess dysfunctional adipose tissue, leading to insulin resistance or impaired glucose tolerance. Stage 2 being metabolic syndrome, hypertriglyceridemia, hypertension, type 2 diabetes, and moderate to high risk CKD. Stage 3 being subclinical disease, and stage 4 being my mother having a heart attack, right? That's what stage 4 is, right? And so what we want to do with this is we want to get people back towards the left. We want to push people left, right? So if you're in stage 2, we want to get you back to stage 1. If you're stage 1, how do we get you to stage 0? And think about preventing disease for individuals around the country and around the world. And to do this, we really talked a lot about a patient-centered implementation focus. So consideration of the social determinants of health. You've already heard the importance of some of that in the first couple of presentations. Access to pharmacotherapies, interdisciplinary care, CKM education, obesity management, which is a huge push at this meeting and a lot of sessions on that. Implementation within and across health centers, as well as supporting healthy lifestyles in communities. So basically, how do you reach people where they are being one of the big keys? And that's really in alignment with the No Diabetes by Heart initiative, right? Where we're really thinking not only about the professionals and all that we're doing in clinics, but also about the people, right? And how they can go on the website and learn more about that connection between diabetes and heart disease. We've done that. I've been honored to work with Jorge and Nancy and other folks on different webinars. If you haven't been on the NoDiabetesByHeart.org, I encourage you to check it out. It's great for providers, but even more importantly, it's great for people and for patients. And so in our research group, we've really had a focus on the individual levels, interpersonal, organizational, community, and public policy levels within the socio-ecological model. And our framework was really to center on equity with community-engaged, diverse teams. As was mentioned, the Accelerate Research Group, we have 4 pillars: epidemiology, quality improvement, health system to community interventions, and community-based participatory research. Health equity is our roof, and academic, community, government, industry partnerships are our foundation. And we really believe in the T0 to T4 paradigm of science. I get to stand here today, but these are all the folks that make the work happen, right? And we're all committed to this pathway and this journey of improving cardiometabolic health. So let's get to what you came here to hear about. So first, let's talk about quality improvement. We have a collaborative in Ohio called Cardi OH, and Scott, I said, or Chris, I said OH? IO, okay, so we got an OH and an IO, good. For those of you not from Ohio, that's a big thing in Ohio. And so we're proud to have that as part of the session. And so in this Cardio OH program, we have 7 medical schools that are working together along with the state and state government to really improve diabetes and cardiovascular disease treatment and care. We utilize this collective impact model, and this collaborative aims to improve diabetes outcomes and advance diabetes health equity. And between 2020 and 2022, with the collaboration of Ohio Department of Medicaid, managed Medicaid plans, and the medical schools, we recruited 20 primary care practices across the state to participate in quality improvement. And our goal here was to reduce the percentage of patients with A1C greater than 9% from 25% to 21%. Our implementation strategies include audit and feedback, peer-to-peer learning, QI coaching, and subject matter expert consultation. And the 6 Medicaid plans align their QI projects with the activities of the QI practices to catalyze improvements in outcomes. So they added coverage for diabetes self-management education support. They removed prior authorizations for CGMs. They aligned quality limits on diabetes supplies, and they piloted home A1C testing. And so in the overall project, we started with a rate of greater than 9% at baseline, and we were able to reduce that to 25% baseline, and we were able to reduce that to 20% over the course of those 2 years. And so that's published in AJPH. Sherry Bolin is the lead author, and there are many cardio investigators here at the conference. Today, I want to talk a bit about the Equity SMART aim. So here our goal was to address racial and ethnic disparities in diabetes A1 control with an emphasis on standardized processes to reduce implicit biases, provider-patient engagement, addressing non-medical health-related social needs, and addressing the impact of racism on care. And through this process, we had many different pieces that were developed. And here's an example of some of these pieces where we had the impact of social determinants of health on emerging diabetes interventions. We're able to educate providers on the importance of that. We utilize our Pathways Community Hub models. This is where you put in a referral and a community health worker is able to work with individuals to address the social barriers that might be impacting their care. And we also had sessions on addressing racism to achieve health equity, in addition to strategies around that as well. And I forgot to say in the beginning, all my slides, you can take a picture. It has Scan Me's on them, so it's probably pretty obvious that you can take pictures of my slides. And so, you know, we started with 5 key elements: the common agenda, shared measurement, mutually reinforcing activities, and continuous communication, as well as backbone support. We had supports for the clinics and providers. We had payer interventions and disparities interventions. And then what we were really measuring was these process measures. So we wanted to try to improve A1C check within 12 months, as well as scheduled follow-up within 12 months as 2 of the primary process measures. And then ultimately our outcome measure. And so we had improvements in the process measures in both the Hispanic American and non-Hispanic Black American groups, as well as we did reach our target of a 20% reduction in A1C greater than 9 in the Hispanic American group, and a 22% reduction in the non-Hispanic Black American group. And that data is there. So next, you know, we talked about, that's the A1C part, right? That's the A and ABCs. The next project is called Achieving Cardiovascular Equity, and it is a blood pressure project, and all the individuals are there on this slide. Our focus was on improving blood pressure control. The emphasis was on advancing health equity in Black patients. So together we worked to identify patients with undiagnosed hypertension, improve management of adults with hypertension, and once again address those social determinants of health. We have a clinical change package that we use as well as patient resources, but every primary care practice was working with a QI coach throughout the project. We had a lot of work on implementing proper BP techniques and increasing access for patients with uncontrolled hypertension to follow up within 35 days. We used our referral networks in the project. And then we had this data feedback loop where we gave feedback to those primary care practices. Some of the benefits were the data feedback, improved patient outcomes, and potential to improve CMS and NQF outcomes. And so how did we do in this nearly 2-year project? We began with a hypertension control rate of 66%, and that increased 8 points to 74% over the implementation period. We were able to improve blood pressure control in white patients from 71 to 76%. Black patients 60 to 71%, so an 11-point change, and Hispanic patients 66 to 74%, an 8-point change. And that paper is currently under review. So next, let me tell you about health systems and community interventions. Another big component of our group is how can we work from the health system and get people out to the community-based interventions that they need. I'm the faculty lead for Exercise is Medicine. And in the Exercise is Medicine program, we get folks who, say, they come in the clinic and say, hey, you got to exercise. They say, I haven't exercised since I was a wrestler in high school. Now it's 40 years ago, right? So I say, okay, great. We got the Exercise in Medicine program for you. They work with a personal trainer for 2 weeks, 8 weeks of group-based physical activity, and then they finish with a 1 week with the personal trainer again. They develop then a plan that they can put forward, and they can take that out to any facility to use that plan. And it's led by Alan Summer, and then Danya Namadi is doing a lot of the data analyses these days. And we use recreation and park sites throughout Columbus, Ohio. And so what we see is about people increase their physical activity by about 1 hour. They have improvements in mental and physical quality of life, reductions in weight, waist circumference, blood pressure, depressive symptoms, and perceived stress. And what I don't have time to show today is that some of our urban, more marginalized communities actually have greater improvements in this program than some of our suburban communities, which is really interesting, and we could talk about that at another time. And we're catalyzing this program right now alongside Google on one side, using Fitbits and what we call a faster program that we're doing, as well as Smart Columbus using Garmin. So how does technology benefit the program? And then the last program I'll talk about is community-based participatory research, which is another pillar of our group. And here we focused on Black men in a program called Black Impact 100. Why Black men? Black men have the shortest life expectancy of any non-Indigenous race sex group. And when we look at this study, we screen about 1,200 men every year in the community. We have a walk with about 20,000 people that come out. We screen about 1,200 over the course of 4 hours. It's incredible. We do, all life's essential aid, including blood sugar, blood pressure, blood cholesterol, all the things. We look for people who have less than optimal cardiovascular health, and we ask them, would they be interested in being a part of an intervention to improve their health? This came out of data that initially we had this mantra at the walk of know your numbers, but people knew their numbers, but the numbers weren't good. And so we needed to improve those numbers. And so it's a community-based lifestyle intervention. It's on the backbone of the diabetes prevention program. So we have 16 diabetes prevention program sessions, and then 8 sessions that were designed actually by the men that have topics including, chronic stress. They have a grocery store tour. They have a financial wellness session, et cetera. And with this program, we've shown reductions in BMI, fasting glucose, total cholesterol, and improvements in diet. And when you put all that together, there's about a 19% lower risk of cardiovascular mortality over the course of the 6 months. We've published on the project far and wide, but one of the important pieces is clinical trial retention of Black men in clinical research, and then the mental health benefits. And currently, we're doing a 340-person randomized clinical trial, where we're also, in addition to looking at life's essential 8, thinking about those underlying biological mechanisms, including cortisol dysregulation, inflammation, and the pro-inflammatory microbiome. And so the last of the two slides here is, you know, at Ohio State, we have a healthy community center. I'm proud to be the medical director for this center. OSU invested over $5 million. All the programming is free. We have everything from cooking classes there. We have a beautiful cooking kitchen there to community-based programming that targets all the social determinants of health, as well as the classic factors that we think about in health. And this is where we're able to actually disseminate some of this evidence-based work into the community to get it to people where they are. So in conclusion, you know, we're all about advancing diabetes and cardiometabolic risk. But the important thing is that this takes all of us. And I think the real key to it is kind of those academic, community, government, industry partnerships and team science being two of the big keys in this area. All of the programs I talked to you about today are all based in that paradigm of kind of academic, community, government, industry partnerships. And with that, I would like to say thank you.
Thank you very much, Joshua. I would like to suggest that your university should be more proud of this program than their football team. This is making a difference to the community, and it's real. And I think the other thing I should say is I whispered to Christopher, do you guys fund this? Yes. This is CDC work, your dollars at work with what Josh is doing, as well as what the other speakers talked about. So thank you, Christopher, for that. We're going to finish now with a commentary on these three presentations by Shivani Patel. Shivani is an associate professor of global health and epidemiology at Emory University. She's a social epidemiologist whose expertise on socio-contextual determinants of cardiometabolic disease development and outcomes. It's quite a mouthful. Her research focuses on the prevention and management of cardiometabolic disease in the US and globally. So Shivani, it's your turn to come and talk to us. And what I would also just like to mention while we're getting Shivani's talk up is that those of you who are streaming this, please put your questions in the chat. When the speakers come up for the discussion, we'll try and address as many of them as possible, as well as those from the audience. So here we go, Shivani.
Enough. Thanks for that introduction, and thanks for this opportunity to discuss these really rich papers. I now have the fun part, right? My colleagues did all the work and produced really beautiful data for us to discuss, and I'm going to warm you up for additional questions and discussion. So I have no relevant disclosures here. So I wanted to begin by talking about the toll of diabetes complications in the US and beyond. So we've heard a bit about it, but I'm going to present a little bit more data just to put us all on the same page. So in 2021, the most recent data we have available, we find that diabetes is the fourth leading cause of disability-adjusted life years in the United States. So that is disability-adjusted life years is a measure that combines both death and disability. And what I think is really remarkable about that number is that not only does it rank very high, it's also increased substantially in proportion. So there's been a 40% increase in diabetes-related DALYs in the past 10 years or so. And that is paralleled only to COVID-19, which didn't even exist, so it can't be estimated, and drug use disorders, which are actually quite small in number. And so this 40% rise is quite concerning. Diabetes-related hospitalizations in 2020 are in the number of 335 per 1,000. So we heard a lot about diabetes-related complications with respect to hospitalizations in Dr. Saley's presentations. But stepping back, this is a very, very large proportion of total hospitalizations. So this is over 20% of total hospitalizations in the United States. And you can see the distribution as expected: major cardiovascular disease, lower extremity amputations, hyperglycemic crisis, and hypoglycemia all contribute to those hospitalizations. We also know that diabetes complications are extremely costly. The total estimated cost of diagnosed diabetes is $412 billion. So that is not to say that the $5 million investment in the comprehensive primary care center that we just heard about is not a small investment. But when we think about the total cost of diabetes just being one of the major chronic conditions in this country, it's just really astronomical. And we know that these financial costs are just just one part of the story. There are enormous social costs. and also health and well-being costs, which of course bring us here today. The age-adjusted comparison of DALYs, I think, is also relevant. So we talk a lot about chronic disease in the United States and how terrible it is. I do want to say that the ranking of diabetes in the United States is on par with the ranking of diabetes in other high-income countries. So I think as much as some things stand out for us in the United States, there's also a lot that we share in common with other high-income countries. And actually, if I were to show you the data on middle-income countries, also you would see some similarities. So there's also a lot that we can learn from one another when it comes to the prevention and treatment and management of these conditions. None of our speakers got into this complication, but I think we, coming out of this pandemic, if I can say that, I think we're squarely out of this pandemic. Diabetes and high blood glucose were critical determinants of susceptibility to severe COVID-19 disease and also poor outcomes. And so this figure happens to show the cumulative number of COVID-19 infections in per 100,000 population by the IDF, that is the International Diabetes Federation regions. And if we were to plot all this out, I couldn't find exactly the right plot. We would find that countries and localities that had high burdens of diabetes also had high burdens of diabetes cases, but also COVID cases, but also COVID-19 deaths. And at least in my own experience, what I found was this put diabetes on the mental radar of our communities in a new way, because people figured that out, that this is not just a hypothetical thing that I need to control my diabetes for future complications. It felt very, very urgent and present for many of the people that we wish to serve. So, the complications related to diabetes are absolutely a global health threat. So we've heard, very interesting presentations on pressure points for the prevention of diabetes-related complications, and I'm going to just briefly summarize what I took from the papers presented today. So we had 3 papers, and I would say that they covered diabetes complications from 3 different vantage points. We had surveillance covered by Dr. Saley and colleagues. We had the analytic epidemiology of retinopathy by Pascal and colleagues, and we had interventions by Joseph and colleagues. So getting onto the surveillance piece, the key questions that this particular paper asked were, how have diabetes complications changed over the past 2 decades in the United States, and how have demographic inequalities in diabetes complications changed in that same period? Some of the key findings that I'm going to take away from this paper is that concerning upward trend in complications overall. And while we knew that from prior data that there was an upward trend, when I looked at these data, I said, well, that wasn't a blip, right? Sometimes we see that there are these short-term increases, and then it looks like, oh, actually, it all just flattened out anyway. I think the paper and data that we saw today established that this upward trend is very real, and it's a cause for concern. We saw also that there was a lack of consistent progress in reducing racial inequalities. So though there was some progress in some outcomes, it was not consistent, indicating that there's still much work that remains. We saw sex differences were stagnant. And I think one of the biggest takeaways is, again, reinforcing what we saw with what we have been seeing with age and complications. So there was a reduction in age-related inequalities, but this was driven by a rise in complications in younger age groups, especially Generation X. So this is all feeling much more real to, I think, me and my cohorts. But we see rising complications in that group. So this reduction in inequality is not always necessarily a good thing, right? We need to look at why there's a reduction in inequality. It wasn't because the older groups were doing better. And I think a key takeaway from this work is that the earlier development of diabetes in more recent cohorts is beginning to show up in complication rates, and we really need to continue to take this seriously. The second paper by Pascal and colleagues asked the key questions of, what is the association between urbanicity, race, ethnicity, and glycemic control with receiving standards of care and progression to vision-threatening diabetic retinopathy. Some of their key findings were, with respect to the standards of care, were that urban patients were more likely to meet standards of care than rural patients. Hispanic patients were less likely than white patients to meet the standards of care, or rather, I should say, receive standards of care. And individuals with poor glycemic control and unmeasured glycemic status were less likely to receive standards of care as opposed to patients with good glycemic control. So as was already mentioned, what we're finding is the most clinically vulnerable patients, looking at that third bullet point, are the patients that are precisely falling through our cracks when it comes to follow-up. Then their work on progression to vision-threatening diabetic retinopathy showed that actually it's urban individuals, excuse me for that typo, urban individuals also were more likely to progress to vision-threatening diabetic retinopathy. Race, ethnicity, ethnic minorities and patients in general had higher risk of progression than white patients. And then individuals with poor glycemic control also were more likely to progress. And so I think taking especially the urban findings, and sorry for the incorrect direction of these arrows, but looking at the standards of care as opposed to what we're seeing in the progression, I think it's a key takeaway for me that progression requires more than just receiving care. We need to think about factors outside of just the clinical system and tracking whether or not these visits are made. And finally, I'm going to focus my attention on the quality improvement work that Dr. Joseph presented. And in that work, they asked the question, can an academic community partnership centered on equity-minded quality improvement reduce the percentage of Black and Hispanic patients with A1C over 9%? And some of the key findings here were that the intervention met its desired target of 20% reduction in poor glycemic control in the three largest racial ethnic groups. So that was including Black and Hispanic patients. But I think it's also worth noting in their data that Black and Hispanic groups had the highest proportion of patients that continued to have the high A1C, and that the intervention had the largest absolute and relative reduction in white patients. So, there are many ways of looking at these data, but one of the biggest takeaways for me here is that equity-minded interventions can benefit everyone. So in a very politically and socially divided time, when we bring up equity, and many of us in this room, I imagine, are brought to this discussion because of our interest in equity, we know that not everyone is as interested in equity or equity-minded interventions. But what I see in these data, and what I see actually time and time again, is that equity is not harming anyone. In fact, equity might be benefiting all of us. So some implications for action that I think emerged from these three papers and bodies of work collectively. I again imagine that many of us in this room hold this point of view that diabetes is both a societal problem and a complex medical problem. And prevention and control must address both social determinants of health and healthcare delivery. So I think what we need to do is think across the cascade. It's not just about glucose control, and it's not just about receiving that clinical care. It's also about who is getting diabetes, and also actions and behaviors that the patients and communities that we're working with are able to undertake. So primary prevention. In people with diabetes, risk factors for diabetes complications remain really, really high. These are some numbers that I pulled from the National Diabetes Statistics Report. So about 1 in 5 of people with diabetes are current tobacco users. 90% are overweight or obese. 1 in 3 are physically inactive. A1C over 7%, so people out of glucose control. It was about half of them. In terms of high blood pressure, 4 in 5, and about 2 in 5 have high non-HDL cholesterol. So there's a lot to be done with just risk factor control, but we know that risk factor control is not just about clinical management in the clinic. It's also about things that happen in the community, things that happen at home. I think we also need to think more and more about primordial prevention. I've already noted how alarming those numbers of regarding complications, rising complications in the younger cohorts is. And, this, I think, should be looked at against the data showing an alarming rise in diabetes in very young people. So these are, again, figures pulled from the National Diabetes Statistics Report. On the right side, you see type 2 diabetes in children aged 10 to 19 years old. And you see a dramatic rise in all groups, but especially in Black non-Hispanic children in this country. We also, so the earlier or rather younger you develop diabetes, that's a longer lifetime duration with diabetes. We know these people, especially younger people, are worse at engaging with care. And there's a potential downward spiral for health that can begin very early and then lead to higher vulnerability to complications. I think another implication for me is the need to enhance and fully leverage data infrastructure. So all of the papers that we heard about today, of course, rely on key data pieces that weren't necessarily collected by them. Each one of these analyses actually relied on national data collection efforts, surveillance efforts, or electronic health records that were maybe collected in the course of routine care, but are now being leveraged for research purposes. So I think there's a critical importance of linking that community data to that clinic data when we think about what the cohorts of the future will look like. And part of that, I think, to maintain this data infrastructure in the current times is to also educate and sensitize the public and policymakers to these needs. That's also talking to our patients and community members about what we're using these data for, and really having some of those conversations about how do we ensure privacy-enhancing methods to allow these communities to be comfortable sharing the data. So clearly you can tell I'm an epidemiologist and I've had certain data streams taken away from me over the years. And that's part of why I'm bringing this issue up, because we would not be able to have the data telling the story they do today if we didn't have some of these streams of data. And I'd like to conclude with a slide that was actually presented by Dr. Joseph, that these solutions, all the solutions we're talking about, really require partnerships. I think integration is really key throughout. I think integration was a theme of also Dr. Pascal's talk as well. So it's not just about integration of care, it's also academic community integration, it's disciplinary integration, thinking about implementation science and epidemiology together, behavioral science and biology together, and also having the folks who are analyzing the data, creating the data, talking to policymakers in ways that it work. And I'll say, the context matters and difference must be respected, but what I'm hearing in this room and what I'm hearing in global settings, there's a lot of similarity, especially when it comes to diabetes management, diabetes prevention, and thinking about, the prevention of complications. And I think engaging in this work, engaging in a collaborative way really has benefits to all. So with that, I would like to conclude my remarks and open it up for discussion. Thank you.
Good morning.
All right, so if the three other speakers would come and sit up here, Christopher's going to run the panel discussion. I just have two things to say. The one is Shivani, when she introduced herself and thanked the other speakers for their work, because they had to do all the heavy lifting with the writing, did not say to you that she is going to be writing a commentary on those three talks in diabetes care, and the pressure is on her because the papers are in to take what you spoke about today and get it forward. And then the last thing I'm going to say is I'll have a special announcement that again relates to the symposium in diabetes care when the panel discussion is over, just to let you know about a new initiative with the journal.
So let's give our speakers one more round of applause. This has truly been a tour de force, and every one of your talks has been very special and poignant. I am going to start inviting people to come to the mics. If you have any questions for either of the panelists or for all of the panelists, please come to the mic. And I think we're going to be checking online to see if there are any that have been submitted to those who are attending virtually. We've got a couple of people coming now. I'll let you kick it off, sir. If you can just say your name and your institution and fire away.
Right, Stefan Jakob from Germany. Thank you very much for the nice presentations. I do have a question concerning the whole concept. We were mainly talking about retinopathy and HbA1c, but you also mentioned the ABCs. I think we keep forgetting that HbA1c could be also an indicator of less adherence to treatment, of less availability for medication, and so on and so forth. In your retinopathy study, did you also look at the relevance of blood pressure control, at lipid control, and achieving the three goals, and then have a look into the outcomes?
That's a great question. Is Jason here? We can hopefully he heard that, so we can he's there. So that's the next step.
Oh, okay,
So there's a lot of questions and things that we want to ask from this database. We're new to it, but I think we can leverage this to try to answer all these questions and try to
just some data we collected in Germany, 4,500 people in German GPs' offices. When you took the highest HbA1c tertile and compared it to the lowest HbA1c tertile, those people in the highest tertile had the highest BMI, the highest blood pressure, the highest LDL, and most of the medications at least listed.
Oh, and I think it's something that we will expect, and there's so many different levels and layers that we need interventions, and I think the work that Dr. Joseph is doing is incredible because he's trying to target all those things together. So I think it's something we're learning.
Yeah. Thank you for your question, and please come up to the mic if you have questions. I have one for Dr. Saley. So in your analysis, you and your colleagues use somewhat newer measures of disparities. Can you elaborate on the added utility of these measures versus standard measures like rate differences?
Yeah, that's a great question. So in trying to track progress in eliminating health inequities and diabetes-related complications, we had considered several different disparities measures. And so rather than using rate differences and rate ratios, which typically have a reference group that's traditionally assigned by people like the groups that with the highest privilege. So for instance, for racial and ethnic inequalities, typically it's like non-Hispanic white, right? So instead of doing that, we had wanted to summarize the inequalities across all the subgroups with a single value, because these measures typically use the population average as a reference group. And so I think that's important because that prevents us from idealizing or like stigmatizing certain subgroups. Also, the measures that we chose, we had wanted to make sure that we were able to account for population size change over time, because I know there's been like a huge demographic shift in the past 20 years, right? So we wanted to make sure we account for that as well.
Yeah, thank you. Oh, we've got a few people at the mic. If you can just say your name and an organization.
Hi, my name is Ling Yang. I'm from Hong Kong Polytechnic University. In Hong Kong, we also start this primary health care by shifting the healthcare to this patient-centered care. So I do have a question for Dr. Joseph, and I'm quite impressed by your talk. It seems to have done a lot of efforts integrating the different parties and stakeholders. But I'm wondering, how did you do to motivate the younger adults? Because a lot of people are having the prediabetes. They're probably not facing an immediate threat of the health problems. So how to motivate those younger adults? And also how to persuade their stakeholders that intervention could be sustainable and also worth the money. So that's my question. Thank you.
Yeah, great questions. And just starting at the youngest. Just starting at the youngest age, when we think about elementary school students and kind of coming forward, you have collaborators at Nationwide Children's Hospital that are working in schools every day on two paradigms. One is the risk factor modification, so physical activity, healthy eating, all those different pieces. The second is actually school-based clinics. So we have school-based clinics in Central Ohio where they're nationwide children actually in the school and able to monitor some of the more high-risk individuals. The second thing I would say is that at the Healthy Community Center, where we're focusing on nutrition and physical activity and mental wellness, and we have a healthy retail cafe and all this different stuff, it's actually geolocated a block from a high school. And so we have partnerships with the high school as well, and a huge focus of that is how do we engage with the high school students. We did sessions with some of the students already, and are planning, it's not started yet, but are planning programming with them around healthy lifestyles and the importance of that in the near term, but to your point, most importantly, over the life course and in the long term.
Yeah, thank you. What about the working adults, like those, 40s, something like that?
Yeah, so
Would be easier.
yeah, when we think about 20 to 50, or in medicine we work till about 85, so 20 to 85, right? Working adults, but all the programming that we have at the Healthy Community Center has been really, we looked at one, kind of evidence-based programs, and two, community input. And so to the point of kind of working individuals, I think one of the biggest barriers is time. And so what we do is we stay open until like 8:30, 9 o'clock, so that we have after work, kind of programming. And the next question that will, some people work second shift or third shift, but we're trying to stay open, at hours where people can access those preventive lifestyle measures and education around those. Not only education, but actually the programming as well.
Thank you very much.
Thank you. We've got two more people in line. Let's take those last two questions and then we'll be at time. But just really quickly before you start, just for Dr. Pascal, if you would, you mentioned tele-ophthalmology or tele-retinopathy. I think maybe you used the term, maybe a potential tool for patients to follow up in their diabetic retinopathy care. What patient level and policy level barriers need to be addressed to implement this as a scalable option in both rural and urban settings?
So I think it's a great question and difficult question. At the patient level, I think what we don't do well is making sure our patients understand what the diagnosis means. So they may get this diagnosis of diabetic retinopathy, and what is next? What does it mean to them? So I think learning a little bit better on how they interpret the information, I think that's important. So in the how we're providing those diagnoses to patients. Patients now can access their charts, can see their notes, but they don't necessarily understand what is happening. So I think there's a lot of work that needs to do. I think to be done at the patient level. At the policy level, I think it's maybe figuring out how the clinics can get reimbursed for telehealth. I sometimes penalizing the health systems encourages the hospitals to start doing better work. So I think that the metrics, meeting certain metrics, so you have to complete this metric so that you can get maybe incentives. So I think there's ideas that we can take from other measures for heart failure, for example, meeting the heart failure metrics. Everybody needs to go after an MI with a statin or all those kind of things. So you have a checklist of things. So I think those are potential.
Excellent. Thank you. Yes, sir.
Hi, Muhammad Ali from Emory University. This was terrific. My question actually is for Dr. Saley, and maybe Dr. Patel could also comment on this, is the data that you presented on national trends and complications I found intriguing. In particular, the idea that, if I understood it correctly, there was an uptick in non-traumatic lower extremity amputations, uptick in heart failure, and an uptick in stroke, but a really flattening or no increase really in myocardial infarction over the last decade. And I wonder whether you can comment A, on that pattern, and you think there is any patterning to it, and B, whether you think there might actually be some influence of ICD-10 coding and or just a greater awareness of heart failure over this last decade compared to what was previous decades.
For the ICD-10, the ICD coding part, in regards to the data, there were crosswalks, because there was a transition from ICD-9 to 10, and so I don't think that had really affected the results. I don't know, Dr. Patel, if you wanted to.
Not on the coding, and I think you accounted.
There's the mic.
Yeah, I don't have anything else on the coding, and I believe you accounted for changing sizes of the denominators. So that might. So I do see the concern, but I think your analytic methods suggested that the finding was robust to some of those concerns. Maybe not the coding part, however.
Yes. Thank you. Yes.
Dr. Hirschler from Buenos Aires, Argentina. Really interesting. Congratulations. I am in epidemiology working with children with type 1 diabetes. And what we found, that's why I think that in Ecuador it may be similar, that 68% of the parents of their children, they had elementary school or less. So they couldn't understand about cards count, etc., etc. Therefore, even if they go to the office and you think that they understand, they don't understand. So maybe it's a very important factor to consider, the level of education and the level of comprehension, because sometimes you think that they understand and they don't understand.
100%, and I think you're addressing health literacy, and there's an interest of talking about personal health literacy and also organization health literacy. So to take a little bit more responsibility for the institutions to make sure our patients is not just on their side that they don't understand or they don't have the education, and low health literacy happens at any education level. So obviously the minorities may have lower levels, but I think it's general. Many of us do not understand what we're seeing sometimes in the charts. So that's a great point.
Okay, so before I turn to tell you about this new exciting adventure, I wanted to mention to those in the audience who were online that if you want to collaborate with anybody who's up here, you should just look them up at their different institutions, and that way get in touch with them. There was also a comment which I think goes to you, Christopher, in the long run to think about, which is, I think, reality, and it comes from presumably somebody who's a primary care physician who says, I think PCPs are not aware of all the resources that are available to help their patients with diabetes. And there may be many different resources, but how do we work to make them more visible and accessible? And I would argue to the physicians, the allied healthcare providers, and the patients themselves. And I would put that to you as a challenge for you and your diabetes translation group to think about. So what's the exciting new initiative? It's simply this. You've sat here today and you say to yourself, this was a great symposium. It would be really good for that fellow who's coming to work with me in 9 months' time to listen to. Or alternatively, there's something I heard, but I didn't quite understand. I want to go back and listen to it. Because you've registered for the meeting, you're able to do that, right? You have a period of time that you can do that. In conjunction with the ADA, what we're going to do going forward is once those come down, and maybe even before they come down, this symposium and the talks will be available in perpetuity for you to listen to. So when the papers come out in print, in the table of contents will be a little icon which you will see on the website, which will allow you to play the symposium for yourselves 9 months from now. You've got a new fellow, you want them to understand what was going on, where this research needs to go. They were not at the ADA. The stuff is not accessible anymore on the ADA website. They didn't come to the meeting, so they didn't get to even hear it, or they were somewhere else. Diabetes Care will have it for you with the papers from these 4 great speakers down the road. So thank you very much for attending, and we hope to see you next year at the next CDC Diabetes Care Symposium.